Hello, everybody. I'm Dr. Al Heuer. I am Terry's partner in A&T lectures. I teach at Rutgers University courses mainly in, believe it or not, healthcare management. I teach at County College of Morris, where I am a clinical instructor in their respiratory care program. I do a bunch of other things, including edit textbooks, among them Egan's Fundamentals of Respiratory Care. 12th edition came out about a year ago, and we just started working on the 13th edition, which, believe it or not, start working on it now, and will be out about 2 years from now, and a couple of other textbooks as well. But I'm not coming to you today, as far as, as a professor at any school or an editor of a textbook or anything along those lines. I'm coming to you instead as a presenter on a topic related to neonatal and pediatric chest imaging. So let's take a look at some of the learning objectives. So we're going to start by reviewing related terminology. So whether you work home care, skilled nursing facility, LTACs, long-term acute care hospitals, almost irrespective of which environment that you work in, there's individuals that are talking about chest x-rays. Again, if it's a skilled nursing facility, it may be an x-ray that was taken at an acute care hospital, a week or two earlier. It may be, if you do work in an acute care hospital, it may be they're talking about an x-ray that was done at 4 or 6 or 8 a.m. that morning. But the terminology is still the same. You're still going to throw around terms like radiolucent, radio-opaque, curly A lines, and things along those lines. So I'm going to, in the ensuing slides, I'm going to actually spend a little bit of time going over some of that terminology. For some, or even many of you, it may be some review. However, for others, it may be information that maybe you knew better several years ago. It's a little bit hazy, so it'll kind of take it out of that haziness and put it in greater focus. I'll also be describing some of the indications, that is the major indications for imaging. We'll spend a little bit of time comparing and contrasting the types of imaging. Now, the bulk of this presentation is indeed on x-rays. So just to kind of lay that out to start with. However, I would be remiss if I didn't do some compare and contrast, looking at x-rays versus CAT scans or CT scans, MRIs, and PET scans. Those would be the 4 major categories of scanning that we're talking about. Deliberately did not spend time on ultrasound, could have, but the time limitations for this presentation really precluded us from taking a dive in that direction. We'll be examining normal images in order to understand and get a handle on what is not necessarily normal. Really need to look at what would be more normal or typical. We'll review some common abnormalities. Now, although this presentation is indeed on imaging, we know that imaging is just one major category of clinical indicators. And in order to assist the healthcare team, the physician, the PA, the nurses, in order to basically assist them with a differential diagnosis, we're looking at a lot of clinical variables, of which the imaging is one major category, but there's many, many others. So what I've chosen to do is, when we look at some of these x-rays, is to talk a little bit more about some of the other common abnormalities that might be seen with these, if you will, abnormal x-rays. And then take a kind of a brief discussion along the lines of what are some of the treatment modalities for it. So for instance, we'll take a quick look at atelectasis. And for our older pediatric patients and obviously adults, incentive spirometry is one of the approaches we use to either preventing or in some cases even treating atelectasis. Okay. In the case of the younger pediatric and neonatal population, that's not necessarily the direction we go in because of a whole lot of reasons, including their ability or lack thereof to follow commands and to basically be able to get a good, tight lip seal to be able to generate sufficient inspiratory flows and things along those lines. But we'll be talking about some of the treatment modalities for these pediatric and neonatal patients that can develop abnormalities, including atelectasis. And probably most importantly, I kind of make this argument that it's very difficult to cover a comprehensive view of pediatric and neonatal imaging in a 50 or 55-minute presentation. So we'll be furnishing you with additional resources for those of you who may be interested in taking a deeper dive on this particular topic. So some of the common terminology and definitions. So X-rays are basically formed from what's called ionizing radiation. So ionizing radiation is the type of radiation that can harm you. So hence, when we're in a room and the X-ray tech comes with a portable X-ray machine, they're asking us to temporarily leave, perhaps help them set the patient up and do what they needed to prepare the patient to actually get the X-ray. But then when they're ready to actually shoot it, they'll have lead on many times, and they'll be asking everybody to leave the room. And time and distance are your friends. You just want to get a safe distance away, because again, ionizing radiation can be harmful. That's the bad news. The good news is ionizing radiation can also be a very, very powerful tool in basically identifying various abnormalities. So the X-ray is a penetrating form, so ionizing radiation, penetrating form of energy. And again, it's just electromagnetic radiation to view body structures. And indeed, individuals like Madame Curie were instrumental in developing this technology going way back. Sort of a little bit of a sidebar on Madame or Marie Curie. For many years after her death, they had tours of her house. She actually died of complications of radiation poisoning. Not a surprise, because they really didn't know the harmful effects at that time. And for years after her death, they had tours of her home until they realized, it took a long time, that it seemed like individuals that worked there, that it would actually, help give the tours and things along those lines, that spent time there, were starting to show various effects of a disorder that they weren't exactly sure, but, hair loss and, higher rates of leukemia, and in some cases even burns, where they actually had, uranium, samples of uranium in the house, et cetera. So someone came up with the brilliant idea to take a Geiger counter and just run it through the house. It was a primitive form of a Geiger counter, and basically the entire house was hot. It was very hot. So step number one was they ceased all tours of Madame or Marie Curie's house, and then they took the appropriate measures in order to clean it up, if you will. It might have been one of our first radioactive toxic waste dumps type of deal. In any event, back on task here. So when we actually talk about, well, was the X-ray taken, was it AP or PA? So anterior, posterior would be front to back. And just to be, completely candid, many of the X-rays that are taken on bedridden patients that are, say, in the ICU, the portable chest X-rays, many of those are AP or anterior, posterior. Posterior anterior or PA X-ray would be for individuals when they're doing a chest X-ray and the person is ambulatory. What they'll have them do is face away from the X-ray machine, lift their the arms, kind of bend their elbows, lift their arms over their head, take a deep breath, and usually there's a voice that will prompt them. Usually it's not actually a person, it's just a voice that's actually built into the whole software. Deep breath, hold your breath, and it's actually taken. One of the advantages to a PA versus an AP X-ray is just much less tissue between the skin surface and the lungs. And again, the main focus of this presentation, when we're talking about chest imaging for neonatal and pediatric patients, is really we're not really looking for trauma per se. We're really looking for other forms of pathology. So AP versus PA. Radio opaque. So radio opaque would appear if you will, whitish, light gray or whitish. So it really has to do with density, unless it's a reverse X-ray, but let's stay away from that right now. So the density which obstruct the passage of energy appearing light or white or light gray on the X-ray. And I just gave you a very brief sampling here, but infiltrates such as consolidation or atelectasis will appear radio opaque or light, light gray or white. Tumors will appear, light gray or white. Even pleural effusions are less distinct because they tend to not be hazy, but they will, if you will, lighten the image itself. Radiolucent, so less dense. So this would be air-filled, darker. Air appearing dark on the X-ray. And then this is where we start to stick our big toe in the water with making these distinctions between or among CAT scan, MRI, and PET scan. So the CAT scan it's actually a series of slices or a series of X-rays to create cross-sectional images. And one of the big advantages of a CAT scan over an X-ray is it can give you this 3D, the depth. By definition, it's actually giving you depth. So for instance, a single X-ray is not telling you the depth potentially of, let's say, a tumor. Some tumors are round or roughly round. Some are not at all. Some are much more deep than they are, if you will, high and wide. They can, really vary. So the CAT scan is giving you, if you will, that depth. The MRI, again, uses a magnetic field and computer-generated radio waves to create much more detailed images, okay? Now, I will tell you, it's not real common to do MRIs on babies. It's not that it doesn't happen, but in certain cases where they would suspect that the baby had, let's say, shaken baby syndrome, where there's all these shearing, injuries to the brain, but not necessarily enough to create an out-and-out hemorrhage, okay? The MRI might actually show that much greater resolution than something like a CAT scan, and certainly more than an X-ray. The PET scan, on the other hand, really shows images of radioactive drug, tracer, to show both normal and abnormal metabolic activity. So in somewhat simplistic terms, what they do is that they have a tracer. Many times it's a glucose substance that's also, if you will, tagged, with radioactive isotopes. And then on top of that, there's imaging. So you can see areas of enhanced metabolic activity, where that I'm going to just say glucose would be, the uptake of it would be much greater. So the PET scan will, quote unquote, light up. And near the end of this presentation, I have a couple of samples that I will gladly share with you. What the mindset is, it'll light up because the cancer, it grows. By definition, it is the uncontrolled multiplication of cells. And then they reach a critical mass and they start producing a tumor, something that's actually visible, sometimes palpable. But what's going on there is this very, very rapid growth. Rapid growth needs oxygen, needs blood, and it needs nutrients. So the PET scan is emulating the actual nutrient part of that. And because it's tagged with radioactive isotopes, that can actually be seen. It can be, if you will, viewed. So major indications, and again, X-ray imaging, but really what we're focusing on, as I said before, for the bulk of this presentation, are X-rays, to determine the positioning of lines, airways, and drains. Lines, airways, and drains. And again, I could go into this immense detail on it, but it's the gold standard. So X-rays are still the gold standard in assessing endotracheal tube placement. And again, for your younger population, mid-tracheal. So basically, it's as you're looking at the X-ray, it's centered. It's not deviating in one direction or the other, unless it's a poor film, unless the child or the baby was not straightened out and it's skewed to one side. Then that can really throw a lot of things off. But assuming that's not the case, that the tube should be mid-tracheal between the inferior clavicle border and the carina. And again, the radiologist would then interpret it, and if the tube needed to be advanced or retracted or whatever, that will be part of the report. Also to view the positioning of chest tubes in your, if you were older pediatric patients, it could be things like central lines, and viewing number one, that they're properly placed, and number two, in the process of placing the central line, the patient didn't sustain a pneumothorax or, pneumomediastinum. In addition, another major indication or category of indications is to detect gross bony abnormalities. So certainly trauma would fall into this category, that, whether it's baby or, a pediatric, a younger or older pediatric patient, accidents, even household accidents, are a common cause of, of doctor visits and hospitalizations in this population. In addition, to examine for lung abnormalities, including but not limited to hyperinflation that you might see with air trapping associated with asthma, with tumors, and it's much less common to see lung tumors of any sort in neonates and pediatric patients. Not that it doesn't occur, it's just much less common than what you might see in older adults, particularly ones who smoked, had occupational exposure, etc. In addition, those abnormalities may include consolidation like you might see with pneumonia, which is where the actual airways are filled with fluid and or mucus. And by definition, consolidation means that you don't have airflow. Atelectasis is a related condition, but not the same as consolidation, where you may not have the airway filled with fluid or mucus, but it's just not inflated. It could be due to, again, if it's in the basilar regions, it could be that the child's in pain. They've had a trauma to their chest, to their ribs. They don't want to take deep breaths, and they develop atelectasis. It may be secondary to even things like a mucus plug. So you have a mucus plug or two or three, and then any of the airways distal or downstream from where those mucus plugs are can become, and often do become, atelectatic. Pneumothoraces is basically looking at pneumothorax, looking at the various forms of air that can accumulate outside of the lungs, but within the chest cavity. And we'll talk about some of the very specific types of conditions, 3 in particular. So in pneumothorax, but there are other related air leak syndrome as well. So in order to have an idea of what's abnormal, good idea to see what's normal. I deliberately chose a pediatric, so a middle to older pediatric patient, because it's basically that you just basically demark these milestones much greater. Now, I'm not going to read this particular slide to you, okay? But one of the things that you can see here is the tracheas and kind of midline at the top there. They're saying that they're labeling, various ribs. They're also, talking about the hilar region of the lung. So right now, I'm looking at that kind of about halfway down, where I'm using my cursor here to show you. The hilar region is where the main stem bronchus go into the lungs, but there's also vessels, so arteries and veins. There's also lymphatics. So it's kind of this area of convergence of, again, of blood, lymphatics, air, etc. So we're talking about that hilar region. They were demarcating the cardiac border and the cardiac, this cardiac silhouette, if you will. So, you have the left border and the right border there, cardiac silhouette. Note what's particularly interesting here is in this pediatric patient, the, if you will, cardiac silhouette is crudely, it's 1/4 to 1/3 of the entire AP diameter. Okay. So it's this lateral diameter that we have here. It's really not that significant. In older patients, not older pediatric, but older patients who have heart failure, in some cases, the cardiac silhouette can exceed more than half of that, lateral diameter. And then you have near the bottom, again, I'm not reading every one of these labels, but near the bottom, you have these nicely formed costophrenic angles. The costophrenic angles are really where the diaphragm, the two domes of the diaphragm, the main muscle of breathing, come essentially in contact with the, with the basilar portions of the lung. And what you'll see, like, in some of the slides that we go over, is for patients that are air trapping, you'll see the, those costophrenic angles, and literally they're angled, kind of as they go, in a medial fashion towards the center of the body, they angle upwards. What you'll see in patients that, let's say the asthmatic who's severely air trapping, you'll see that flattened. So you won't see that angle up like that. In patients that have pleural effusions, you'll see a kind of this haziness. You may still see the lung behind it, but you just see this kind of gradual haziness where you have gravity doing its thing and there's fluid buildup, in the pleural space, so in between the visceral and the parietal layers. That lubricate, again, the lung to facilitate lung expansion. So elements of the actual interpretation. So this is a younger patient. Looks like it's, it could be an infant or a young pediatric patient if they're labeling it as a pediatric patient. But the initial assessment, of the X-ray should include the technique of the exam. Sometimes they're skewed, sometimes they're underdeveloped, sometimes they're overdeveloped. The nice thing today is we're not reliant on a static film. Is if it's underdeveloped or overdeveloped, this is all computer stored, computer generated. A lot of times you can make various adjustments real time to adjust for a poorly taken, if you will, film. Include patient positioning, proper exposure, degree of inspiration, etc. And again, obviously your neonatal patients, they're not going to be able to follow commands. So when you ask them to take a deep breath, chances are, that's not necessarily going to happen. But certainly when you get into your, middle and older pediatric patients, so they should be able to do that just fine. Position of all, as I say, tubes, lines, evaluation for these gross abnormalities that will take a little bit of a deeper dive: pneumothorax, Pneumomediastinum, Pneumopericarium, and then looking at mediastinal and cardiac silhouettes. Kind of referred to them a little bit in the prior slide. Airways and lungs, and then the pulmonary vascular pattern. So in some patients that are fluid overloaded, even in this patient population, you'll see vessels. So you'll see, some vascularity there that you normally wouldn't see because the vessels can become engorged. So we'll see some of this as we proceed through this presentation. So the first group of X-rays and conditions I wanted to look at are airway obstruction. Okay. Now, rather than read down in order here, I want to just throw at you guys that the last one listed here, asthma. Okay. What I've done is that one I'm going to discuss in more detail about midway through this presentation. Okay. The others, the foreign body, the croup, and the epiglottitis, I'll be talking about in the pursuing slide. So let's take a look. The other thing I want to say is airway obstruction is a common form of morbidity for younger pediatric patients. Putting things in their mouth, putting toys, having a piece of hard candy that has not fully dissolved, a small cap to a small bottle type of deal. They're putting all this stuff in their mouth, and sometimes they just eat it and next day they poop it out. Sometimes they don't, they can actually inhale it. When I'm working with the respiratory students and they're just finishing their first semester, so they're still babes in the woods, it's, we're giving treatments, we're doing assessment, we're listening to breath sounds. We are actually looking at X-rays, even though I go lightly on that with first semester students. But what I say to them is, when you're in the patient's room and you've done all, you've gathered your equipment, you washed your hands, you identified the patient, you introduced yourself, blah, 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 blah. You've done all that good stuff. Okay. Now you're actually getting ready to give the treatment, and you twist the top off of the unit dose, let's say duoneb, or the half dose albuterol, the 1.25 albuterol. If you drop that little top that you've twisted off, if you drop it in the bed, you better find it. You better find it with any patient, okay? Because that little top can become one of these foreign bodies that we're talking about here. So without going too far down that, let's take a gander. So this particular X-ray, and I ruthlessly stole this from one of my textbooks. So it's figure, obviously it's chapter 6. It really talks about X-rays, in this case, pediatric and neonatal X-rays. But this particular one is expiratory frontal chest radiograph, or X-ray, shows A normal decrease in left lung volume. Okay, tooth, and we're really looking at this right here, obstructs the right main stem bronchus, causing air trapping in the right lung. Now, when you look at this X-ray, and you're almost saying, it looks like the pathology is on the other side there. This is really not particularly well developed. Okay, it's not, I mean, the film itself. But when you come over to where the arrow is pointing and you're looking at the actual left lung, you're saying, well, that kind of looks all right there. It's hyperinflated. There's actually a flattening. It's not entirely flat, but a flattening of the costophrenic angle owing to the actual lung being hyperinflated. Taking it a step further, if we were actually auscultating this patient, they well could have grossly diminished breath sounds on the affected side. Depending upon what's actually going on, if you think about it, this is the right main stem bronchus. So they're probably experiencing some distress. We're not talking about a segment or a lobe. We're talking about an entire lung here. So they're probably experiencing some sort of discomfort and air starvation and increased work of breathing and that sort of thing. So treatment is they're probably going to get a bronchoscopy. I'm thinking it's probably going to be the trouble with foreign objects like this is many times, even with small forceps, it's very difficult to extract the tooth or extract, the hard candy will dissolve. It could be problematic because in dissolving, it may kind of shed some bacteria throughout that section there, but it's quasi-organic. It's going to break down. Okay. A tooth is not, we know that the enamel is not going to break down. So this patient may actually end up getting a rigid bronchoscopy in order to actually facilitate the removal of the tooth. Now let's just transgress a little bit. Now I know this presentation is on mainly chest imaging. So I'm being sneaky here, okay? Because what I'm saying is many times when they're doing a chest X-ray, is they're also getting the trachea. And in the normal chest X-ray that I showed you earlier, we're actually looking at the trachea, okay? Now one of the things, the testing board. So if we have any nurses in the audience, great. We're happy to have you. But for the respiratory therapists, they had to take their exam or exams from what's called the NBRC, the National Board for Respiratory Care. And the National Board for Respiratory Care, they like to ask questions that help ensure that exam candidates can distinguish or help distinguish between disorders that may appear somewhat similar. So they'd like to compare, croup with epiglottitis. So I'm very conspicuously spending a little bit of time examining this distinction and examining what you might actually see in a chest/neck X-ray on a patient that has croup versus epiglottitis. And one of the findings that you'll see with a patient that has croup is, and you won't see it 100% of the time, but you'll see it in a surprisingly large percentage of cases, is a steeple sign. So the steeple sign, the arrow, this black arrow is pointing here, I'm kind of circling it here. The narrowing, okay, so that the actual steeple itself is not tissue, it is the airway, it is the trachea. But what's happening is, again, the upper air with the tissue around it is swollen and it is compressing. Now, the bad news is it's very swollen, okay, and the steeple sign is almost classic. The good news is there's still some patency there. So, again, one of the things that you're actually looking at in making this distinction between croup and epiglottitis. With epiglottitis, what you can often see is what's called the thumb sign, okay? Now, the steeple sign with croup was the opening. The thumb sign is not the opening. The thumb sign is the swollen, epiglottis and tissue around it, okay? So again, an experienced clinician and really experienced doctor/radiologist will be able to look at this and say, this is what it's supposed to look like. This is not what it's supposed to look like. And that swollen epiglottis is really, and tongue is really showing you, this, what they call the thumb sign. Now, briefly, making the distinction between epiglottitis and croup, epiglottitis is bacterial in nature, tends to have a more rapid onset than croup. Kids tend to be sicker. So, they will look ill. Most of them will be hospitalized. They may have stridor. They often will have stridor with epiglottitis. The patient may be kind of leaning forward and drooling because it's simply too difficult, too painful for them to swallow their own saliva, secretions, and they would just let it, basically run out of their mouth. May need emergent care and airway management. So the patient that has epiglottitis, they may, it's not a good idea to allow or let the beginner, the individual who hasn't done many intubations, and pick this patient and say, let me try type of deal. This is not the patient you want to try on, because the patency of the airway is probably very small to start with. It's not going to take much for them to completely lose their airway. Croup, on the other hand, is viral. So antibiotics are not indicated. Versus epiglottitis, it's a more gradual onset. The illness would tend to be not as severe, so mild to moderate illness. Occasionally or sometimes results in hospitalizations, but not as frequently as epiglottitis. And the care for it is mainly supportive care, where the care for epiglottitis may include supportive care, but they're also getting started on antibiotics as well. And again, the airway management is an issue. So let's take a look at infant respiratory distress syndrome. Many causes. So IRDS, many causes, and I don't mean to imply in this slide that these are the only ones, but in infants, a common cause is prematurity. So as we remember, we've learned, maybe some of you actually work in the NICU environment, where you get premature infants. One of the things with prematurity is that the cells that actually produce surfactant are not fully mature. So it's not unusual for premature infants, infants that are very premature, not by a week or two, to need surfactant replacement therapy. And even with that, they may have still some difficulty with shearing pressures and work of breathing, and manifest itself in many ways. But things like retractions, respiratory rate, the color of the baby, their oxygenation, their pulse oximetry, et cetera, et cetera. So one of the major causes of IRDS, is prematurity. Now in just respiratory distress syndrome, in now your pediatric patients, okay, would be more pneumonia, near drowning, some form of an inhalation injury, possibly aspiration as well. And one of the other, if you will, kind of causes or can be actually one of the part of the sequelae of IRDS is bronchopulmonary dysplasia. And with the babies that have bronchopulmonary dysplasia, it's this, well, now they're improving, but they have the kind of these abnormal tissue formation in the lungs, mainly because they've had some fibrotic changes due to their IRDS. They're kind of, if you will, growing out of it. By the way, a lot of them will sort of pretty much grow out of it type of deal, because they're so young and their recuperative powers are so strong, that many of them will grow out of it if we can support them through the process. The problem with IRDS and bronchopulmonary dysplasia is that, in some cases, the pneumothoraces, Pneumomediastinum are common complications because they've been, many of them have been exposed to positive pressure ventilation with high airway pressures and concomitant low compliance. So they're really apt to develop various forms of, if you will, air leaks. This is a chest radiograph looking at a patient with ARDS, and this would be more of a older pediatric patient. Infiltrates in all 5 lobes. Air bronchograms. Air bronchograms are basically where on each end of the say the secondary, tertiary bronchus, they're actually constricted and air actually gets trapped. Okay, get trapped. It actually shows you can better see, and really your air bronchograms would be like in through here and through here. You're not supposed to be able to see this. In this particular case, you are. And then it appears as a result of areas of consolidation and loss of lung volume. So there's consolidation here and here, but you have these air bronchograms around here, this one here as well. So manifestations and treatment, bad news is that, the kid has, IRDS, or the pediatric patient has ARDS. But the good news is that there's treatment. Some of the other clinical manifestations, however, would be hypoxemia, hypercarbia, so the blood gases showing both carbon dioxide retention as well as low blood oxygen, increased work of breathing, a gradual loss of airway, if you will, pressures, low compliance, increase in airway pressures, low compliance, retractions would be common as well, decreased breath sounds because, again, parts of the lung are not well aerated. Treatment, mechanical ventilation tend to be higher FiO2s, higher PEEPs. Remember, when we get worried with the babies about them developing retinopathy or prematurity, certainly they're at risk for that. But it's not the FiO2 that actually causes the vessels in the eye to constrict. Okay, it's not the FiO2. It's the SO2 and the PO2. So it's what makes it into the blood. So some of these patients, just to have reasonably acceptable saturations, they need high FiO2s and high PEEPs. Just be sure, the team just needs to be sure that they're monitoring blood gases and monitoring pulse oximetry. So as the child improves, that we're not over oxygenating and over peeping them. Nasal CPAP, as they start to improve, in particular, whether it's bubble CPAP or just through a ventilator that just on that particular mode. Oscillatory ventilation in more extreme circumstances. Surfactant replacement is very common. In the olden days, we used to do kind of reverse CPT. Now it's just side to side. Some places just instill it down the ET tube and just let it do its thing. ECMO. What I can tell you definitively is ECMO is actually used less. It's used less in this patient population, and it's not because it doesn't work. It's used less in this patient population because some of the babies do better without it. In other words, they do better than they did in the past. There's more therapeutic tools in our toolbox than 10, 20, and 30 years ago, where we had to resort to ECMO because we didn't have all those tools. I alluded to this, tip in my hand, bronchopulmonary dysplasia, so premature treated with supplemental oxygen. So maybe the ones that maybe they were on mechanical ventilation on a prolonged basis, maybe they weren't, but they're supplemental oxygen. The alveoli are not mature enough to function normally, and it can be a part of the sequelae, as I said, from IRDS. And some of the treatments for this may include part of the sequelae to IRDS is BPD, then certainly surfactant may be part of the, if you will, the treatment plan. Kinder, gentler forms of mechanical ventilation. And then you're actually giving, if you will, around the time of birth, before birth, that the mom is given corticosteroid treatment in order to hasten the maturity of the types of cells that produce surfactant. It's a little bit on a BPD. So just to make this comparison, old before surfactant and steroids. Okay, so you're actually kind of seeing this one slide here, particularly on the left side there. The lung is not well aerated at all. And then in the new and improved BPD after surfactant and steroids, pardon me, you're actually seeing considerably better aeration. And some of the, some of the pathologic hallmarks are larger subflat alveoli, dysmorphic pulmonary vasculature. They're minimized. They're doing much better. And then if the baby is indeed on mechanical ventilation with surfactant administration, you'll see things like, volume, if they're on pressure regulated volume control, forms of ventilation. You're gonna get more bang for the buck for the same delta P. You're gonna get higher tidal volumes. Compliance will improve. So that just overall we're better able to give kinder and gentler mechanical ventilation to these kids. Pneumothorax. So here's a right-sided tension pneumothorax. So when you're actually looking at that right side there, this area here that's really if you will, radiolucent here. Okay, radiolucent, it's really dark. Okay, that's not the lung. Okay, that's the lung cavity. Okay, the lung is where this is right here, because what's happening is the air that's, if you're outside of the lung and in this cavity, is compressing the lung. Okay, so and then it's a little bit difficult to see, but they're talking to it at least. So right-sided tension pneumothorax, drained by intercostal drain. There's a flattening of the diaphragm. You're looking at here, shift of the midline with compression of the lung. So let me be clear that if the trachea shifts, okay, and it's a unilateral pneumothorax, it's going to shift, if you will, away from the affected side. So that air is pushing that's outside of that lung, is pushing the anatomy to the other side. You can see, yeah, sorry, just wanted to. So manifestations and treatment, the manifestations, I don't mean to like say that the manifestations for a pneumo or similar to IRDS, but some of them are, hypoxemia, increased work of breathing. The third one is really significant. So when you have a child, if the patient has IRDS doesn't develop in 5 minutes or 10 minutes or a half an hour. Okay, it develops over hours and days. Whereas something like a pneumo may occur literally in a minute. So what you have is you have an abrupt increase in if you will, ventilatory pressures, and an abrupt decrease in compliance, retraction. So a lot of these things that are happening have, the baby was stable 1 minute and then much less stable, 1 minute, 5 minutes, 10 minutes later type of deal. Again, looking at decreased breath sounds, particularly on the affected side, and tracheal deviation away from the affected side. Treatment of small may be self-resolving, but we're really talking about something that's clinically significant. Chest tube insertion would be the standard of care. And just a little, I'm not going to spend a lot of time on this, but a little bit of elaboration on, actually they probably transilluminated the kid, but there's other ways as well. Obviously, they could have done it through an X-ray and just using a hemostat to actually, put a chest tube in place. And then a little bit, without spending a ton of time on this, a little bit of guidance, if you will, on chest tube sizes for age, and really looking at not just for age or for category, but also the intersection of that with their specific abnormality, pneumothorax versus empyema versus a hemothorax. So they're going to kind of vary a little bit. Air is better able to be evacuated than fluid. So in the main, particularly when you're talking about blood, you're looking at using a slightly or somewhat larger chest tube size for a hemothorax versus let's say a pneumothorax. Another air leak syndrome, so Pneumomediastinum, and then this is where the gold standard for diagnosis of a Pneumomediastinum, and I will show you one later on. I do have one in this presentation. Is a CAT scan. 1/3 of cases are not visualized on the X-ray because of the 2D versus the 3D. Treatments of surgery and washout if there's an esophageal tear that's present, that's really causing or significantly contributing to it. Often no significant interventions are required, and they can be somewhat self-resolving. The patient's monitored carefully. Bed rest and pain management would be really critical in the ensemble of treatments as well. Pneumopericardium, where you can actually see the air that's actually trapped here, around the heart. You can imagine that it can be a medical emergency if that amount of air is large enough and it can actually compress, the vessels. It can be very, very problematic. Treatment is aspiration or pericardial tube placement in most cases. So predisposing factors are, sometimes you're trying to fix one problem or buy time for IRDS. The kid has low compliance, you have to high ventilatory pressures, and then develop one of these air leak syndrome. So it's just one of those things that can be, very, very troublesome, but also potentially treatable. Atelectasis, most atelectasis is subsegmental, so we're saying can be very localized. Discoid is where it's actually occurring, and you can kind of see the reason why I call it discoid is you'll see kind of a line, and it's really kind of at the base of the layer where perhaps one segment meets another. It's not the entire segment, but just a portion of it. Ipsilateral mediastinal shift. Okay, all ipsilateral mean, fancy word, means it's not contralateral, it's not the opposite side. Okay, that the mediastinal shift, okay, the tracheal shift will go towards the atelectasis if it's severe enough, ipsilateral or towards the affected side, versus a pneumo that's away. Diaphragmatic elevation, you can imagine that, basically you have underinflated lung, so that diaphragm is going to actually elevate. Crowding of pulmonary, vascular and interstitial markings. And then, looking at, an example of the upper, right upper lobe atelectasis. So minor fissure would shift upwards, and this, triangular wedge opacity because of the actual shape of the right upper lobe. A little bit there, atelectasis. This is obviously a pediatric patient. You can actually see where those arrows are. So atelectasis. And the thing is, you don't really see too much. You see a little bit of line there, but you really have kind of, what's significant here is this. This is actually a right lower lobe atelectasis, where it's pretty well, defined type of deal. Manifestations and treatment. So clinical manifestations, fever. The fever may be because it's some sort of secondary to some sort of an infective process. The fever may be also due to the stimulation of what's called pyogenes, cells that are responsible for fever. And for some reasons they don't fully understand is that there is a higher rate of fever in individuals that have atelectasis, not all of whom have an infectious process. So fever, decreased breath sounds, tachycardia, hypoxemia, increased work of breathing, retractions. If severe, tracheal deviation towards the affected side, Treatment, CPT, suctioning, bronchodilators, mucolytics, pediatric hyperinflation, or percussive ventilation. So maybe things like a cough later. It may be, like a Medaneb. But again, not with your babies, but it may be with your very, very young children. You could use both the coughlator or inexaflator, and with some success. Neonatal bubble CPAP, surfactant replacement would be included in your ensemble as well. Pneumonia, and you're really looking at upper right lobe pneumonia here. So you're seeing that there. This is obviously a very young pediatric patient. So you're seeing it both AP or anterior posterior, but you're also seeing a lateral as well. So it's really more in the upper, if you will, posterior, which is where you can often find if a kid aspirates that they can develop. It also do with the bronchus that are feeding that particular if you will, lobe of the lung is more apt. The actual positioning of it is more apt to be problematic if the kid aspirates. Manifestations of here, you're gonna have fever. This more than infectious fever. Increased white blood cells, unilateral expansion, decreased breath sounds, tracheal deviation towards the affected side, etc. Treatment, potentially antibiotics. We know that we're using antibiotics much more judiciously today. Antipyretics, CPT, bronchodilators, etc. Neonatal bubble CPAP, surfactant replacement. So there's some commonality in this treatment as well. Hyperinflation associated with asthma. So this is a pediatric patient. You're seeing big rib spaces. So it's, if you guys don't look at a lot of x-rays, you can't look at this and say, well, this looks pretty normal to me. Well, it does, but these lungs, if I showed you this and then this with the pediatric patient 2 weeks later after they're out of this crisis, you'd see that the lungs don't look quite as big rib spaces. There is some flattening of the costophrenic angles type deal. So you're really looking at, if you will, hyperlucencies, a lot of blackness there, a lot of air. And again, you're not just making a diagnosis of asthma based on an x-ray. You're obviously looking at their history, breath sounds, you're looking at, maybe perhaps eosinophils, the whole, their history. Or have they had prior episodes? Wheezing or decreased breath sounds. It's going to sound weird. I like to hear wheezing because in order to have wheezing, you got to have air movement. Decreased breath sounds in a patient, an asthmatic patient that looks acutely ill is no bueno. It's suggestive that they're so constricted, their airways are so profoundly constricted that they're not moving air at all. Hypoxemia, hypercarbia, increased work of breathing, high airway pressures, resistance, etc. So, basically looking at your peak inspiratory pressure versus your plateau. So your plateau is obviously compliance. Your difference between PIP and plateau is your resistance. The total is what's known as total impedance. But in this case, the difference between peak inspiratory pressure and plateau is greater. It's greater. It's increasing. Retractions are common as well. Treatment, continuous bronchodilators, perhaps wean to intermittent, Heliox therapy, particularly for your pediatric patients, systemic steroids, and in some cases, in fact, they require intubation and mechanical ventilation, and concomitant, potentially in concomitant systemic steroids, Heliox, continuous bronchodilators. So it's not like these are just used alone. They can be used as an ensemble of treatment modalities in the context of a treatment plan. Cystic fibrosis. So you get these early changes and you get this, this progression that goes on, but the early changes are peribronchial thickening, atelectasis, air trapping. But then as it progresses, so this, mucoid impaction, bronchiectasis because of the repeated infections. So now you have, irregularities and pocketed, if you will, airways, lobar atelectasis, scarring, pulmonary artery and right ventricular enlargement because you actually have this issue of the lungs have been bad for a period of time. The body constricts the vessels that are serving the lungs in general, and the right heart preload can be significantly increased. Overinflation can be an issue as well because of the combination of several of the above factors. Cystic fibrosis just doesn't, this is, it looks to be crudely put, looks to be, a 6 or 7 or 8 year old, something along those lines, but really not good at all. And what's really disconcerting, it's really diffuse, where the hilar regions really look bad. But then you also have these, opacities that are really occurring on pretty much throughout the lung in general. So these lesions, these infections and scarring, et cetera, is pretty much, throughout the lung regions with, again, this hilar region looks completely consolidated. Manifestations and treatments, so the testing, identifying through a sweat chloride test or pretty much genetic testing is pretty much the standard these days. Repeated respiratory infections, increased work of breathing, retractions, digestive problems because they have pancreatic insufficiency as well. So it's not just a lung issue. Fatty stools owing to patients that have cystic fibrosis do not digest fats very well. They can do an okay job if they're getting supplements, that is digestive supplements or enzymes, but not so much if they're not. Declining PFT. So what typically happens is, over a period of months and years, their pulmonary function testing can further decline. And I'm really talking about their steady state, not when they come in and they're really sick, but before they go home, they're now steady state versus their PFTs, this time last year or this time 2 years ago. They're pretty much a steady decline. Treatment, aggressive CPT and pulmonary toileting, percussive ventilation, PEP therapy, bronchodilators, mucolytics, antibiotics for bacterial infection, digestive enzymes, and lung transplantation if it's advanced. Kids are living with CF are living into their adulthood, but they're not necessarily living to their 50s and 60s. There are, isolated cases like that, but many times by the time they reach their 30s and early 40s, they're hopefully candidates for lung transplantation. Hopefully they're not too sick for that. That's really what I meant. Other imaging, so we're kind of coming down the home stretch a little bit, as I'll show you a few other of them as well. So CT scan, I know I alluded to this earlier, a series of x-rays to create cross-sectional images, reveals 3D dimensional needed for depth. And often it's very helpful, particularly for like staging, in cancer, for determining the extent of a bleed, in the brain, where an X-ray is showing, in one direction, but it's not showing you how deep it is. MRI, again, uses magnetic field computer-generated radio waves to create detailed images, much greater detail resolution than the chest X-ray and even a CAT scan. Ultrasound, I did throw it in here, use sound waves to create images, so heart function, also for pleural effusions, for the size and the location, if the candidate is possibly a eligible or potentially a candidate to have a thoracentesis. The ultrasound is what they're using to actually localize where they're going to thoracentesis and where they're going to actually drain that fluid. PET scan, again, the images of radioactive drug tracer to show both normal, abnormal metabolic activity. Their use can detect biological changes, precede visual ones. So this is really a key point. You're really detecting, in some cases, discrete changes. Think about it. It's almost changes in metabolic uptake, in if you will, glucose uptake that are not really visible or fully visible to that extent through other imaging. And again, biological changes, increased uptake, which may precede visual ones that can be shown on images. Often used to distinguish benign from malignant masses, potentially identify sites of cancer metastases. CAT scan of a pneumomediastinum. Okay, we are actually looking at the pneumomediastinum. Okay, is this darkness here? Okay, this darkness right in here. We have early. This is lung. This is lung. Base of the heart. This is the spine. This is the air. That's in the mediastinum. That's actually pushing the lungs outward. They're helping. They're actually hindering, but they're helping inhibit lung expansion, and they can also result in a cardiac tamponade where it's squeezing the heart as well. A chest X-ray and CAT scan of cystic fibrosis are really showing you this particular this image labeled 3A. It does not look as advanced as the one that we saw a little bit earlier on. There are some you can see some lesions here, infiltrates, right kind of in the hilar region, also in the lower portion of the medial portion of the lung. But then you see much better resolution, if you will, in 3B, which is the CAT scan. And it's showing you where that consolidation is in the airway and showing you with much better resolution than the chest X-ray can. So the MRI example, to give you an idea there, it's just giving you, even when you look for a second outside the lung, look at this dome of the diaphragm, how much better that you can actually see it, okay? How you can see the humerus in the shoulder here. So the degree of detail there's no comparison, degree of detail in doing an MRI versus, a CAT scan or certainly an X-ray. The thing is, MRI, it's, the kid has to hold still, it's an enclosed area. It's more expensive. It's more expensive. It's more involved than some of the other imaging that we're describing here. CAT scans versus PET scan. Now, this, in all candor, is really looking at an older adolescent or an adult patient, really, so that we can get the size image we're looking at here. But you see, the CAT scan is showing you some suspicious, if you will, nodules, if you will. The PET scan is showing you where it actually lights up. So it looks like there's a nodule, there's the aorta, but there's a nodule near it, which certainly lights up here. I'm giving you a much better idea that there's actually a nodule that's scary, that's very close, in a scary fashion, very close to the aorta. There's some selected sources. Among them is the Egan's Fundamentals textbook. We have actually 2 chapters in the textbook. One just relates to chest imaging. The other one relates to pediatric and neonatal disorders, which talks about some of these specific disorders. My clinical assessment in respiratory care textbook that just literally came out has, again, a chapter on chest imaging as well as on pediatric and neonatal abnormalities. This piece by Garcia and others, which talks about pitfalls and variants in pediatric chest imaging. So it's really very interesting. It's fairly new out there. It's written in a pretty understandable way. And then you can go to your, if you will, search engines, PubMed, Medline, the AARC, for any nurses or other clinicians in our audience. The AARC is the American Association for Respiratory Care. And with that, I want to thank you guys very much for attending today's session. Hopefully you've learned something from it. And we really hope that you come back and join us again. Thanks a lot and have a great day.